Principles of antibacterial chemotherapy. Bacteria, a common cause of disease, but have beneficial as well as harmful effects. For example, the gastrointestinal bacterial flora of the healthy human assists in preventing colonization by pathogens. Widespread use of antibacterial drugs has led to the appearance of multi-resistant bacteria, which now significant cause of morbidity and mortality. Consequently, antibacterial therapy should not be used indiscriminately. Distinction is conventionally drawn between bactericidal drugs that kill bacteria and bacteriostatic drugs that prevent their reproduction, elimination, depending on host defense. This difference is relative, as bacteriostatic drugs are often bactericidal at high concentrations and in the presence of host defense mechanisms. In clinical practice, the distinction is seldom important unless the body's defense mechanism depressed. Antibacterial drugs can be further classified into 5 main groups according to their mechanism of action. The choice of antibacterial drug together with its dose and route of administration depend on the infection. In particular, responsible pathogens, but also anatomical site and severity, absorption characteristics of the drug, and patient factors. In particular age, weight, renal function. In addition, the dose may be guided by plasma concentration, measurements of drugs with a narrow therapeutic index, for example, aminoglycosides. The duration of therapy depends on the nature of the infection and the response to treatment. Close liaison with the local microbiology laboratory provides information on local prevalence of organisms and sensitivities. The minimum inhibitory concentration, MIC. It's the minimal concentration of a particular agent below which bacterial growth is not prevented. It's in vitro test in homogeneous culture system, whilst in vivo, the concentration site of infection may be considerably lower than the plasma concentration, which one might predict to be bactericidal. For example, drug penetration and concentration in abscess cavity are very low. The resistance of bacterial population to antimicrobial agents is constantly changing and can become a serious clinical problem, rendering previously useful drugs inactive. Overdose of antibiotics will lead to a future when infections disease has some impact since the pre-antibiotic era. Current guidelines therefore emphasize the following points, and you can see on slide 3 main status. No prescribing of antibiotics for colds or viral infection. Limit prescribing for uncomplicated cystitis to 3 days for otherwise fit women. And third, limit prescribing of antibiotics over the telephone to exceptional cases. Antimicrobial resistance is particularly common in intensive care units and transplant units, where the use of antimicrobial agents is frequent and the patients may be immunocompromised. The evolution of drug resistance involves selection of naturally resistant strains, which have arisen by spontaneous mutation that exist within the bacterial population by elimination of the sensitive strain by therapy. So the incidence of drug resistance is related to the prescription of that drug. The hospital environment with intensive and widespread use of broad-spectrum antibacterials is particularly likely to promote the selection of resistant organisms. And second, transfer of resistance between organisms can occur by transfer of naked DNA transformation by conjugation with direct cell-to-cell transfer of extra chromosomal DNA plasmids, or by passage of the information by bacteriophage transduction. In this way, transfer of genetic information concerning drug resistance frequently to a group of several antibiotics simultaneously may occur between species. Mechanism of drug resistance can be broadly divided into 3 groups. Inactivation of the antimicrobial agent either by disruption of its chemical structure, for example, penicillinase, or by addition of modifying group that inactivates the drug, for example, chloramphenicol inactivates by acetylation. Second, restriction of entry of the drug into the bacterium by altered permeability or efflux pump, for example, sulfonamides and tetracycline. And last, modification of the bacterial target. This may take the form of an enzyme with reduced affinity for inhibitor or altered organelle with reduced drug binding properties, for example, erythromycin and bacterial ribosomes. Most infections can be treated with single agent. However, there are situations in which more than one antibacterial drug is prescribed concurrently to achieve broad antimicrobial activity in critically ill patients with undefined infection, for example, aminoglycoside plus penicillin to treat septicemia, to treat mixed bacterial infection, for example, following perforation of the bowel in cases where no single agent would affect all the bacterial present. To prevent the emergence of resistance, for example, treating tuberculosis, and to achieve an additive or synergistic effect, for example, used of quatrimoxazole in the treatment of pneumocystic carinea pneumonia. Prophylactic, preoperative antibiotics, general principles. Prophylaxis should be restricted to cases where the producer commonly leads to infection, or where infection, also rare, would have devastating results. The antimicrobial agent should preferably be bactericidal and directed against the likely pathogen. Their aim is to provide high plasma and tissue concentration of appropriate drug at the time of bacterial contamination. Intramuscular injections can usually be given with premedication or intravenous injections at the time of induction. Drug administration should seldom exceed 48 hours. Many problems in this area arise because of failure to discontinue prophylactic antibiotics, a mistake that is easily made by busy junior house surgeon who doesn't want to take responsibility for changing prescription for patient who is apparently doing well post-operatively. Local hospital drug and therapeutics committees can help considerably by instituting sensible guidelines on the duration of prophylactic antibiotics. And if continued administration is necessary, change to oral therapy post-operatively very well possible. Common prescribed antibacterial drug, beta-lactam antibiotics. These drugs each contain beta-lactam ring. This can be broken down by beta-lactamase enzymes produced by bacteria, notably by many strains of Staphylococcus and Haemophilus influenza, which are terribly resistant. Beta-lactam antibiotics kill bacteria by inhibiting bacterial cell wall synthesis. Antibiotics in this group include the penicillin, monobactams, carbapenems, and cephalosporins. And first group is penicillins. Use benzylpenicillin, penicillin G, is a drug of choice for streptococcal, pneumococcal, gonococcal, and meningococcal infection, and is also useful for treatment of anthrax, diphtheria, gas gangrene, leptospirosis, syphilis, tetanus, Yavs, and Lyme disease in children. Adverse effects include anaphylaxis in approximately 1 in 100,000 injections. Next, rash. Near 5% of patients can rarely be severe, for example, Stevens-Jones syndrome, serum sickness, type 3 hypersensitivity. Other idiosyncratic reaction including hemolytic anemia and thrombocytopenia. In renal failure, high-dose penicillin causes encephalopathy and seizures. Limitation of benzylpenicillin include its acid label and so must be given parenterally. It has a short half-life, developed of resistant beta-lactamase producing strains can occur. It has a narrow antibacterial spectrum. Two preparations with similar antibacterial spectra are used to overcome the problems of acid lability, frequent injection. Procaine benzylpenicillin. This complex releases penicillin slowly from intramuscular site, so twice daily dosage only is required. Phenoxyl methylpenicillin, penicillin, this is acid stable and so is effective when given orally, 60% absorption. Although it's useful for mild infection, blood concentration and variables, so it's not used in serious infection or with poorly sensitive bacteria. Tablets given on empty stomach to improve absorption. Beta-lactamase resistant penicillin. Flucloxacillin was developed to overcome beta-lactamase producing strains. Otherwise, it has a similar antibacterial spectrum to benzylpenicillin, is effective against beta-lactamase producing organisms. It's used for the treatment of staphylococcal infection, 90% of hospital staphylococcus resistant to benzylpenicillin, and 10% are resistant to flucloxacillin. Extended range penicillins, amoxicillin together or ampicillin uses in addition to streptococcal strains, including pneumococcal infection. Ampicillin and amoxicillin also effective against many strains of Haemophilus influenza, Escherichia coli, Streptococcus faecialis, and Salmonella. They are used for variety of chest infection, for example, pneumonia, bronchitis, otitis media, urinary tract infection, biliary infection, and the prevention of bacterial endocarditis. Usually we use amoxicillin. Amoxicillin is somewhat more potent than ampicillin, penetrates T-cell beta and is given 3 rather than 4 times daily, both susceptible to beta-lactams. Side effects. Rash, common and may appear after dosing has stopped. There is especially high incidence in patients with infection, mononucleosis, or lymphatic leukemia. Pharmacokinetic, the half-life of each group is about 1.5 hours, and they are predominantly renally excreted. Next drug, co-amoxiclav. It's a combination of amoxicillin and clavulanic acid, beta-lactamase inhibitor. In addition to those bacteria, there are susceptible to amoxicillin, most Staphylococcus aureus, 50% of Escherichia coli, some Haemophilus influenza strains, and many bacteroids and Klebsiella species susceptible to comoxiclav. A side effect similar to those of amoxicillin, but abdominal discomfort is more common. Next, antipseudomonal penicillins. Standard penicillin are not effective against pseudomonas. This is not usually a problem. This organism seldom causes disease in otherwise healthy people. However, pseudomonas infection is important in neutropenic patients. For example, those undergoing cancer chemotherapy, and in patients with cystic fibrosis. Penicillins with activity against pseudomonas have been developed and particularly useful in the circumstances. These include piperacillin, ticarcillin, and azlacillin. These expensive intravenous penicillins are not used routinely. The efficacy agent gram-positive organism is variable and poor. They are useful against gram-negative infection, particularly with pseudomonas, and they are also effective against many anaerobes. Their drugs have synergistic effect when combined with aminoglycosides in pseudomonas septicemias. Combination of ticarcillin or of piperacillin with beta-lactams inhibitors designed to overcome the problem of beta-lactamase formation by pseudomonas are commercially available. Side effect: these drugs predispose to superinfection, rash, sodium overload, thrombocytopenia, and platelet dysfunction can occur. Pharmacokinetics: absorption of this drug from the gut is underquate in the life-threatening infection for which they are mainly indicated. They are given intravenously every 4 to 6 hours. Their half-lives range from 1 to 1.5 hours, and they are renally excreted. Cephalosporins, first-generation cephalosporins, so-called first-generation cephalosporins, for example, cefaclor, cefadroxil, cefalixin. There are effective agents, Streptococcus pyogenes and Streptococcus pneumoniae and Escherichia coli and some Staphylococcus. They have few absolute, for example, inequally advantageous indication. Their pharmacology is similar to those of the penicillins, and they are principally renal elimination. Second and third generation cephalosporins. They are active against Haemophilus influenza and in some instances pseudomonas and anaerobes at the expense of reduced efficacy agent to gram-positive organism. Beta-lactamase stability has been increased. Arguably, the most generally useful member of the group is cefuroxime, which combines lactamase stability with activity agents Streptococcus, Staphylococcus, Haemophilus influenza, and Escherichia coli. It's given by injection aid hourly and oral preparation is also available as cefuroxime acetyl. It's expensive also when used against gram-negative organisms that would otherwise necessitate the use of aminoglycoside. This cost is partly offset by saving from the lack of need for plasma concentration determination of the third generation cephalosporins, ceftazidime, ceftriaxone, and cefotaxime, useful in several sepsis, especially because they penetrate the blood-brain barrier well and they are effective in meningitis, unlike early cephalosporins. Side effect: about 10% of patients who are allergic to penicillins are also allergic to cephalosporins. 10%. Some first generation cephalosporins nephrotoxic, particularly if used with furosemide, aminoglycoside, or other nephrotoxic agents. Some of the third generation drugs associated with bleeding due to increased prothrombin times, which is reversible with vitamin K. Monobactams, for example, Astrianum, contain 5 monobactam ring and resistant to beta-lactamase degradation. Astrianum. It's a primarily active agent aerobic gram-negative organisms and is alternative to aminoglycoside. It's used in several sepsis, often hospital acquired, especially infection of the respiratory, urinary, biliary, gastrointestinal, and family genital tracts. It has a narrow spectrum of activity and cannot be used alone unless the organism's sensitivity to astrianum is known. And mechanism of action. A 5 monobactam ring binds to bacterial wall transpeptidases and inhibits bacterial cell wall synthesis in similar way to the penicillins. Side effect. Rash occur, but there appears to be no cross-allergenicity with penicillins. And pharmacokinetics. Astrianum is poorly absorbed after oral administration, so it's given parenterally. It is widely distributed to all body compartments, including the cerebrospinal fluid. Excretion is renal, and the usual half-life 1 to 2 hours in increased in renal failure. Imipenem, cilastatin, and meropenem. Imipenem, carbapenem is combined with cilastatin, which is inhibitor of the enzyme dehydropeptidase 1, found in the brush border of the proximal renal tubule. This enzyme breaks down imipenem in the kidney. Imipenem has a very broad spectrum of activity agents, gram-positive, gram-negative, and anaerobic organisms. It's beta-lactamase stable and is used for treating several infections of the lung and abdomen, and in patients with septicemia, where the source of the organism is unknown. Meropenem is similar to imipenem, but is stable to renal dehydropeptidase 1 and therefore can be given without cystatin. Side effect. Imipenem is generally well tolerated, but seizures, myoclonicus, confusions, nausea, hypersensitivity, vomiting, test disturbance, positive Coombs test, and thrombophlebitis have all been reported. Meropenem has less cirrhosis-inducing potential and can be used to treat central nervous system infection. Imipenem is filtered and metabolized in the kidney by the dehydropeptidase 1. This is inhibited by cystatin in the combination. Imipenem is given intravenously as an infusion in 3 or 4 divided daily doses. Next drug, aminoglycosides. There are highly polar surge containing derivatives. There are powerful bactericidal agents that are active against many gram-negative organisms and some gram-positive organisms with activity against Staphylococci and Enterococci facies, but not against other Streptococci when used alone. They synergize with penicillin in killing Streptococcus faecalis in endocarditis. Aminoglycosides used in serious infection, including septicemia, sometimes alone but usually in combination with other antibiotics, cephalosporins or penicillins. Gentamicin is widely used and has a broad spectrum, but is ineffective against anaerobes, many streptococci and pneumococci. Tobramycin is probably somewhat less nephrotoxic than gentamicin. Amikacin is more effective than gentamicin for pseudomonal infection and occasionally effective against organism resistance to gentamicin. Is principally indicated in serious infection caused by gram-negative bacilli that are resistant to gentamicin. Topical gentamicin or tobramycin eye drops are used to treat eye infection. Mechanism of action of aminoglycosides. These drugs are transported into cells and block bacterial protein synthesis by binding to the 30S ribosome. Side effect. There are important and related to duration of therapy and through plasma concentrations. They are more frequent in the elderly and in renal impairment. Therapeutic monitoring is performed by measuring plasma concentration before dosing throws and at peak levels, usually at arbitrary 1 hour after dosing. Nerve damage is potentially catastrophic and often irreversible. Acute tubular necrosis and renal failure are usually reversible if diagnosed promptly and the drug stopped or the dose reduced. Hypersensitivity is uncommon. Bone marrow suppression is rare. Exacerbation of myasthenia gravis predictable in patients with this disease. And pharmacokinetics of aminoglycosides. They are poorly absorbed from the gut and are given by intramuscular or intravenous injection. They are poorly protein bound, 30%, and excreted renally. The half-life is short, usually 2 hours, but once daily administration is usually adequate. This presumably reflects post-antibiotic effect. Variably, bacterial growing is inhibited following clearance of the drug. In patients with renal dysfunction, dose reduction and increased dose interval is required. Cerebrospinal fluid penetration is poor. Drug interaction. Aminoglycosides enhance neuromuscular blocker of non-depolarizating neuromuscular antagonists. Loop diuretics potential their nephrotoxicity and ototoxicity. Next drug, chloramphenicol. It has a broad spectrum of activity and penetrates tissues exceptionally well. Mechanism of action. Chloramphenicol inhibits bacterial ribosome function by inhibiting the 50S ribosomal peptidyl transferase, preventing peptide elongation. Side effect. This includes hematological effects. Dose-related erythroid suppression is common and predictable, but in addition, aplastic anemia occurs unpredictably with incidence of approximately 1 to 40,000. This is irreversible in 50% of cases. It's rarely, if ever, relative to the use of eye drops. Second, gray baby syndrome. The gray color is due to shock, hypotension, and hypoperfusion. Chloramphenicol accumulated in neonates, especially if premature, due to reduced glucuronidation in the immature liver. And third, other thermos diarrhea, encephalopathy, and optic nephritis. Pharmacokinetics. Chloramphenicol is well absorbed following oral administration and can also be given by the intramuscular and intravenous routes. Is widely distributed and cerebrospinal fluids penetration is excellent. It mainly undergoes hepatic glucuronidation, but in neonates this is impaired. Drug interaction. Chloramphenicol inhibits the metabolism of warfarin, phenytoin, theophylline. Next group, macrolides. Macrolide antibiotics, for example, clarithromycin, erythromycin, azithromycin, have antibacterial spectrum similar, but not identical to that of penicillin. Distinctively, they are effective against several unusual organisms, including chlamydia, mycoplasma, legionella. Erythromycin uses include respiratory infection, whooping cough, Campylobacter enteritis, and non-specific otitis. Respiratory infection, including mycoplasma pneumonia, psittacosis, and Legionellous disease. Erythromycin is a useful alternative to penicillin in penicillin allergic patient. Except meningitis, it doesn't penetrate the cerebrospinal fluids adequately. It's useful for skin infection, such as low-grade cellulitis and infected acne, and is acceptable for patients with infective exacerbation of chronic bronchitis. It's most commonly administered by most 4 times daily. So when necessary, it may be given by intravenous infusion. Mechanism of action, macrolides bind to bacterial 50S ribosomes and inhibit protein synthesis. Pharmacokinetics, well absorbed orally and distributed adequately to most sites, except the brain macrolides inactivated by hepatic N methylation, 15% being eliminated, unchanging in the urine. Food delays absorption by may reduce gastrointestinal side effects. Side effects, erythromycin is remarkably safe and may be used in pregnancy and in children. Vomiting, nausea, diarrhea, abdominal cramps, and most common adverse effect reported related to direct pharmacological actions rather than allergy. Cholestatic jaundice has been reported following prolonged use. Intravenous administration frequently causes local pain and phlebitis. Erythromycin inhibits cytochrome enzyme and causes accumulation of theophylline, warfarin, terfenadine. This can result in clinically important adverse effect. Azithromycin and clarithromycin, each of these has greater activity than erythromycin against Haemophilus influenza. Tetracyclines uses tetracyclines, for example, doxycycline, oxytetracycline, tetracycline, have a broad range of antibacterial activity covering both gram-negative and gram-positive organisms, and in addition organisms such as rickettsia, chlamydia, mycoplasma. They are used in atypical pneumonias and chlamydial and rickettsial infection and remain useful in treating exacerbation of chronic bronchitis or community acquired pneumonia. They are not used routinely for staphylococcal or streptococcal infection because of the development of resistance. Tetracycline used in the long-term treatment of acne. Mechanism of action. Tetracycline binds to the 30S subunit of bacterial ribosomes and prevent binding of the amino acid transporter RNA to the ribosome acceptor site, thereby inhibiting protein synthesis. Side effects include vomiting, diarrhea, and nausea. Include pseudomembranous colitis due to Clostridium difficile reported occasionally. Hypersensitivity reaction, including Stevens-Jones syndrome, exfoliated dermatitis, rash, urticaria, angioedema, anaphylaxis, pericarditis. Next. Worsening of renal failure, hepatotoxicity, very rare, discoloration and damage of the teeth and bones of the fetus in the mother takes tetracycline after the 5th months of pregnancy and of children. They should therefore avoid it in pregnancy and children under 12 years. Pharmacokinetics. Tetracycline are well absorbed orally when fasting, but the absorption is reduced by food and antacids. They undergo elimination by both the liver and the kidney. The half-life varies between different members of the group, ranging from 6 to 12 hours. The shorter action drug are given 4 times daily, and the longer action once daily. Doxycycline is given once daily, can be taken with food, and is not contraindicated in renal impairment. And drug interaction, tetracycline chelate calcium and iron in the stomach, and the absorption is reduced by the presence of antacids or food. Sodium fusidate. Fusidate acid is combined with other group to treat staphylococcus infection, including penicillin-resistant strains. It penetrates tissue, including bone, very well. It's normally used in conjunction with flucloxacillin for serious staphylococcal infection. It's also available as eye drops for the treatment of bacterial conjunctivitis. Mechanism of action. It inhibits bacterial protein synthesis, and side effects are rare, but include cholestatic jaundice. Pharmacokinetics. When administered either orally or intravenously, its half-life is 4 to 6 hours and is excreted primarily via the liver. Next drug, vancomycin. Uses and antibacterial spectrum. Vancomycin is available in the treatment of resistant infection due to Staphylococcus pyogenes. It's also rarely used to treat other infections, for example, Staphylococcus epidermidis, endocarditis, and is given orally to pseudomembranous colitis caused by Clostridium difficile. Mechanism of action, vancomycin inhibits bacterial cell wall synthesis. Side effect includes hearing loss, venous thrombosis, red man syndrome, hypersensitivity, and nephrotoxicity. Pharmacokinetics. Vancomycin is not absorbed from the gut and is usually given as intravenous infusion, except for the treatment of pseudomembranous colitis. It's eliminated by the kidneys because of its concentration-related toxicity. The dose is adjusted according to the results of plasma concentration monitoring. Next drug, teicoplanin has a longer duration of action, but is otherwise similar to vancomycin. Next, metronidazole. Uses. Metronidazole is a synthetic drug with high activity against anaerobic bacteria. It's also active against several medically important protozoa and parasites. It's used to treat trichomonal infection, amoebic dysentery, Gehr disease, gas gangrene, pseudomembranous colitis, and various abdominal infections, lung abscess, and dental sepsis. It's used prophylactically before abdominal surgery. Mechanism of action. Metronidazole binds to DNA and causes strand breakage. In addition, it acts as electron acceptor for flavoproteins and ferredoxins. Side effects include nausea, vomiting, peripheral neuropathy, convulsion, headache, hepatitis. Pharmacokinetics. Metronidazole is well absorbed after oral or rectal administration, but is often administered by the relatively expensive intravenous route. The half-life is approximately 6 hours. It's eliminated by combination of hepatic metabolism and renal excretion. Dose reduction is required in renal impairment. And drug interaction. Metronidazole interact with alcohol because it inhibits aldehyde dehydrogenase and consequently causes disulfiram-like reaction. It's a weak inhibitor of cytochrome P enzymes. Sulfonamides and trimethoprim inhibit the production of folic acid at different sites of its synthetic pathway and synergistic in vitro. There is now widespread resistance to sulfanilamide, and they have been largely replaced by more active and less toxic antibacterial agents. The sulfametaxazole, trimethoprim combination, cotrimoxazole, is effective in urinary tract infection, prostatitis, exacerbation of chronic bronchitis, and invasive salmonella infection, but with the exception of pneumocystis carini infection when high doses are used. Trimethoprim alone is generally preferred as it avoids sulfanilamide side effect, whilst having similar efficacy in vivo. Sulfanilamide generally well absorbed after oral administration and are widely distributed. Acetylation and glucuronidation are the most important metabolic pathways. The many precipitated in acid urine. Sulfonamides and trimethoprim side effects. They frequently cause unwanted side effects, including hypersensitivity reactions such as rash, fever, and serum sickness-like syndrome and Stevens-Jones syndrome. Rarely, agranulocytosis, aplastic anemia, hemolytic anemia, megaloblastic anemia, and thrombocytopenia occur. Sulfonamides oxidant and can precipitate hemolytic anemia and glucose 6-phosphate dehydrogenase deficiency in individual its reaction of idiosyncrasia. Sulfonamides potential the action of sulfonylurase oral anticoagulants, phenytoin, and methotrexate due to inhibition of the metabolism. Trimethoprim is well absorbed, highly lipid soluble, and widely distributed. At least 65% is eliminated, unchanging in the urine. Trimethoprim competes to the some renal clearance pathway creatinine. It's generally well tolerated by occasionally causes gastrointestinal disturbance, skin reaction, and bone marrow depression very rarely. Additionally, the high doses used in the management of pneumocystic pneumonia in immunosuppressing patient cause vomiting, which can be improved by prophylactic antiemetics drug. Higher incidence of serious skin reaction, hepatitis, and thrombocytopenia. Quinolones. Nalidixic acid was available for many years, but poor doses and distribution and adverse effect limited its use. Second or third line treatment for urinary tract infection. Changes to the basic quinolone structure dramatically increase the antibacterial potency of the more modern quinolones, particularly against Pseudomonas. Oral bioavailability is good, and those 4 fluoroquinolones offer an oral alternative to parenteral aminoglycosides and anti-pseudomonal penicillins for treatment of Pseudomonas urinary and chest infection. Also, the 4 fluoroquinolones have a very broad spectrum of activity. All of those currently available have very limited activity against streptococcus. Most experience has been obtained with ciprofloxacin, which has additional advantage of being available for intravenous use. Quinolones inhibit bacterial DNA gerase. Bacterial DNA gerase enzyme uses. Ciprofloxacin is used for respiratory but not pneumococcal, urinary, gastrointestinal, genital infection, septicemia, meningococcal, meningitis contacts. In addition to Pseudomonas, it's particularly active against infection with Salmonella, Shigella, Campylobacter, Chlamydia, and Neisseria. It's ineffective in most anaerobic infection. Quinolones. The licensed indication for the other quinolones are more limited. Ciprofloxacin is generally well tolerated, but should be avoided by epileptics. It rarely causes convulsion. Children, it causes arthritis in growing animals, and individual with glucose 6-phosphate dehydrogenase deficiency idiosyncrasy. Side effect. Vasculitis, anaphylaxis, nephritis, hepatic and renal damage, dizziness, renal damage have all been reported. And excessively alkaline urine and dehydrogenase can cause urinary crystallization. Pharmacokinetic, approximately 80% of oral dose of ciprofloxacin is systemically available. It's widely distributed, entering all body compartments, including the eye and cerebrospinal fluid. Ciprofloxacin is removed primarily by glomerular filtration and tubular secretion. The half-life is 4 hours. Drug interaction. Co-administration of ciprofloxacin and theophylline causes elevated blood theophylline concentration due to inhibit of cytochrome P enzymes. As both drugs are epileptogenic, this interaction is particularly significant. So, and you can see in this slide key points, and thank you for your attention.